Hello, I am Laurel Brennan, host of this podcast, Get to the Root of It, and founder of Root Causology, where I help women optimize brain health and reduce dementia risk by addressing, of course, root causes. Today on the show, you will meet Gary Stapleton, President and CEO of Aerodiagnostics. His company provides breath tests to clinicians trying to help their clients and patients optimize their gut health. A healthy gut supports a healthy brain. It is so important that in the guide, My Top 10 Brain Wellness Tips, 5 of the 10 tips are connected to gut health in some way. You can check out that guide at rootcausology.com/top10. That's www.rootcausology.com/TOPTEN. Now let's dive into one specific area of gut health, SIBO, the acronym for small intestinal bacterial overgrowth. Welcome. I am Laurel Brennan, and we are on Get to the Root of It, and I'm very excited to be here with Gary Stapleton today. Hi, Gary.
Hi, good morning. Thanks for having me.
Absolutely. So I found Gary recently because he was giving a webinar through Rupa Health, which is the company I usually use to get my functional tests. And Gary was talking about SIBO, and SIBO has come up fairly frequently with my clients, and most people have never heard of it. So I said, Gary, please come on and share some knowledge, because I think this is a critical area of information to share. So I'm going to read a little bit about Gary. So Gary Stapleton has an extensive background in the business side of the healthcare space. It started in the 90s after leaving the Marine Corps and getting his MBA, with multiple positions and over a decade at AstraZeneca, and then to VP of Sales and Marketing for Bausch & Lomb. In 2009, he began his career move into precision and personalized medicine, first with Caris Life Sciences. He launched their molecular diagnostic, and then as CEO of Lerner Medical Devices. You're currently president and CEO of Aerodiagnostics, providing the highest level of diagnostic accuracy and customer service for patients and clinicians. And this is a SIBO test, correct?
Yes, we do SIBO breath tests, so small intestinal bacterial overgrowth, and then we also do lactose, fructose, and sucrose intolerances.
Okay, very good.
All
So you
from breath.
explained a little bit. Can you go into more detail about what it is that you do now, and kind of what was the journey that led to where you are?
Sure, thanks, Laurel. So what Aerodiagnostics does is measure breath samples to determine if, as we just mentioned, is there an overgrowth of bacteria in the small intestine. The small intestine is not sterile, but it's nearly sterile. It doesn't have a lot of bacteria. The term is less than 10 to the 3 colony forming units of bacteria. The large intestine, or the colon, has a lot of bacteria, more than 10 to the 12. So when you have a situation where there's an infection, there's bacteria or archaea growing in the small intestine, what happens is the bacteria or the archaea will feed on a food source, food or drink. So every time you eat or drink, it'll feed that bacteria. That bacteria will ferment. That fermentation process is what yields hydrogen and or methane gas. Our bodies don't naturally produce these gases. It's a byproduct of the fermentation of a food source with bacteria. So if you're a patient and you're every time you eat or drink, you have bloating or cramping or nausea, joint pain, even no gut issues. Maybe it's restless leg syndrome. Maybe it's skin issues like rosacea. It could be because there's an overgrowth of bacteria in the small intestine. And if it is, what we do is we provide a breath collection kit that a patient will take home, comfort of their own home, and they'll prep for the collection of their breath. So the day before, 24 hours before they collect their breath. So typically the day before, they'll start a limited diet, like chicken, fish, eggs, turkey, white rice, white bread. Then after that, and typically overnight, they'll fast, so water only. So then what happens is they wake up the next day, they are up for about an hour to get normalized breath, flow. And then they'll start collecting breath over a 3-hour period. So they'll take one breath sample and then they'll drink a substrate. So it depends on which kit was ordered. It's either going to be a product called lactulose, not lactose, but lactulose. And then the other product is glucose. So one of those substrates will be mixed with water. Patient will drink that, and then they'll continue to collect breath every 20 minutes for the balance of 3 hours. Then when we get the specimens in the lab, we're going to look for hydrogen or methane gas within the first 2 hours. If we do at certain levels, that tells us that there's an overgrowth. Shouldn't be there. So if we do find that, then a clinician will take this data and their clinical impressions, and they'll decide how to treat. And I think we're going to talk about that in a minute, so I'll base on that. The other tests that we do are lactose, fructose, and sucrose intolerances. Now, these tests, a lot of times clinicians will say, well, if dairy bothers you, then you're lactose intolerant. Matter of fact, they did that with my mother 40 years ago. And guess what? For 40 years, she avoided dairy. And guess what? She's not lactose intolerant. So just going on that is not a good way to know, one, if you have SIBO or not, or two, if you have an intolerance or not. Let's check and see, control the environment for food, do the substrate, let's see what the results say, and then let the clinician make the diagnosis. So that's kind of the baseline. So why did I start this? I think that was the second part of the question. Well, as Laurel had mentioned, I was in pharma, but that was decades ago, and it really went into diagnostics. And so I was working on a project with a toxicology company. And about that time, the project was coming to an end. And about that time, and I didn't know anything about SIBO then. This was almost 10 years ago. But my daughter was dealing with some of these issues. So went to the clinician, and the clinician said, well, maybe it's SIBO. Back then, they said, and I was living in Boston, here, I'm going to order this test. You call this number. I called it was at the Brigham and Women's. Brought her, we got the prep, which I didn't feel was a good direction on the prep. And that's so important. We'll talk about that. But then had to bring her down. They didn't schedule it till 1 o'clock in the afternoon. So you can imagine the fasting for that, how difficult that is, especially for a younger, child. And then, you fight your way through the city, you fight your way for parking, you find the hospital, you're going down into the basement, you're trying to, I just saw how inconvenient it was. So at first it was, well, I can make this more convenient for patients with what I told you about providing the kit at home where they collect the breath. And then, but then I started noticing how I'm not going to be able to trust the data. I could see this from how the technicians didn't understand it. They did it maybe once a week. They're younger, technicians maybe didn't really understand. They're kind of reading instructions and talking to patients. I said, I'm not going to get anything useful out of this. So it was a combination of convenience and accuracy. And then I really learned when I got in what was going on in the treating environment. So you have a lot of clinicians, well-intentioned, that either don't know anything about SIBO or don't want to know anything about SIBO. If they feel like there's an infection, oh, I'll give you some antibiotics. And that was it. No testing, it just was not a good place. So now we've really come a long way. There are guidelines, and there's been a lot of research in the space. And I think we're going to talk about this too. We'll talk about how big the prevalence is in the United States and worldwide. But we have done so many things in the lab to be sure that these numbers that we're giving to the clinician, these hydrogen and methane numbers, are so very accurate. And the great news is it's absolutely binary. If the patient preps well, if the patient is provided a kit, and we'll talk about that later, that is a good kit. It's never opened up to room air. It's almost like if you have your blood drawn, they use a vacutainer. They stick the needle in your arm, they switch out the tubes. Same kind of process. But you're not punctured. You're puncturing a test tube for the breath test. So if that all happens and the lab does the kind of things that we do in the lab, then these numbers are absolutely accurate. So if you have a level of hydrogen or methane gas in a certain place, it'll help validate whether or not this is an overgrowth or an intolerance, or if you can rule it out, which is one of the better situations. Okay, it's not SIBO or it's not an intolerance. And because SIBO-like symptoms can look like a lot of things, parasites, allergies, food intolerances. There's so many things, that fungal overgrowth, that kind of thing. So there's so many things that you want to be able to know for sure before you start on a journey of antibiotics or herbal antimicrobials or elemental diets, that some of the choices for treatment. But so we know for sure what we're dealing with. So now we've come a long way. And I think we'll be talking a little bit more about some of the things I touched on.
Yeah. Review. We'll dig a little bit deeper into some of the things that you shared.
Sure.
So for people who are hearing this for the very first time, so SIBO is an acronym, small intestinal bacterial overgrowth, where, yes, we're supposed to have lots of bacteria in our large intestine, but if it gets up into our small intestine too much, it can be a problem. Excuse me, clients that come to me, it's usually not the first thing they mention. It's usually, an hour or a week or a month or 2 months down the road where they start to talk about, I get so bloated, so full after I eat. I feel like I'm full after I have a couple bites. I can't eat anymore, but I think I'm still hungry. Or so now we know kind of what SIBO stands for. We mentioned a little bit of the symptoms. Can you go over more of what symptoms might be?
Sure. And let me piggyback on something that you said, which is very, very interesting. And those that are listening right now, I'm sure you'll be shaking your head. The reason it takes so long for the patients to present this to their clinician is typically they've had this situation for so long that they don't really remember what feeling good is. Hey, this is how I feel every day. Because remember, if you have an overgrowth, if we're talking about SIBO, it doesn't matter what time of day, what day of week, what type of food. Yeah, certain foods you'll get more bloated or whatever, highly fermentable foods. But the fact is, this is your stasis now. This is how you are as a human being. You don't even remember what good was. So over time, you start to think about it as you're working with a clinician. So maybe it's bloating, maybe it's cramping, maybe it's nausea, maybe it's joint pain, maybe it's, as I mentioned, restless leg syndrome, rosacea, constipation, and or diarrhea, right? So it could be a lot of these things. Maybe it's peripheral neuropathies, which means tingling or numbness, hands or feet. Maybe it's issues with light and or noise. How about, it's a term called interstitial cystitis, but what that means is like burning urination or bladder irritation. How about body pain, body ache? That's fibromyalgia, right? Or how about that gas that, yes, I have gas, but it has that really horrible odor, that rotten egg odor. These are all some of the things that might lead us to a consideration for SIBO that we want to test and confirm. And by the way, I wanted to kind of step back on something too, because I don't know who may be listening, but the small intestine, if you're not familiar with it, if you've ever seen kind of like a caricature of the inside of the human body, you have your mouth, your throat, your stomach, then it looks like a bowl of spaghetti. That's 23 plus feet of a tube. And that tube carries food through into the large intestine or the colon before it exits the body. That's the small intestine. And that's where an infection can occur. And it can occur for lots of reasons. I think we're going to talk about that. But those are some of the things. If you're feeling some of those things, it may not be SIBO. It may not be intolerance. Your clinician will guide you to which direction they feel. Because again, you could have, it could be, the cramping could be a result of a permeability issue. These organs are supposed to move food and drink through. Sometimes it leaks out, so leaky gut, or like I mentioned earlier, parasites or fungal overgrowth. There's so many things for the clinician to consider. Nowadays, thankfully, they know to consider SIBO. As we mentioned earlier, by years past, they didn't. And so now, you're by and large, you're moving in the right direction by talking with your functional, integrative, naturopathic, gastroenterologists, all these folks are well aware, mostly, of SIBO. And those that aren't can certainly feel free to reach out to us, and we're happy to help them.
Yeah, you had a good list of symptoms that can be associated with SIBO, and I'm going to add a couple more
Great.
because I'm in the world of brain health and sometimes brain fog and systemic inflammation, which is a root cause of just about every other problem. So, yeah, like I mentioned, in my world, very often one of the first things we do as an intervention is an elimination diet. Let's see how the body, responds when you're eating healthier food. And sometimes eating healthier food is what opens our eyes to an issue, because they've been eating very bland foods because everything makes them feel bad. And then all of a sudden they're adding in cabbage and broccoli and cauliflower, and then they're having horrible stomach pains or gas, bloating, diarrhea. And that's when we start to scratch our head and say, maybe this is SIBO. So you mentioned some foods. Do you want to talk about FODMAPs? Is that something that you're comfortable talking about?
So I don't really specialize in the diet end of it. So I know, obviously we know that a lot of the clinicians will put their patients on low FODMAPs diet. And that's, so fermentable foods are trying to keep them away from fermentable foods. I'm sure you can talk more intelligently about the diet than I can. But that goes hand in hand with those folks, to your point, that the clinician considers might be dealing with an infection like SIBO or even fungal. That, there's reasons to have these folks on that diet. But for me to talk about, what constitutes some of the foods, I would probably be out of my specialty. Can I jump on one thing? Because you said brain health, right?
Yes.
And I don't know what your thoughts are on this, but the one thing that we've noticed, especially with those that have had SIBO for a very long time, whether they knew it or not, is you have a high level in those patients of anxiety and or depression as well. And why wouldn't you? Every time you put food or drink in your mouth, you don't feel well. That's not surprising. And what touches me, and I can tell you, it shocked me when I first started doing this work, but now it's almost commonplace, at least weekly, if not more than several times a week. We'll have patients that'll get very emotional when they get their test back and it's positive. They'll say things like, almost verbatim every time, now I can tell my family and show them that I'm not crazy. It's not in my head. And it's very comforting to be able to give them that ammunition, that support, so that makes them feel like, hey, there is something we can do about it.
Right. Absolutely. Yeah.
Sorry to take you off the food list.
No.
I didn't mean to do that.
Very, very helpful for you to share that, because there's such a profound link between the brain and the gut. And studies are showing more and more the link. Information travels from the gut to the brain and the brain to the gut through the vagus nerve. And so, yes, it's understandable that someone with a SIBO infection has depression, anxiety, brain fog, and it's literally not just, quote unquote, in their head. They're not making this up. This is for real, for real. Yeah. So what about prevalence? How common is this?
So what we're learning from the research is potentially 4% of the worldwide population, 80% of IBS sufferers, and we're still scratching the surface of research in SIBO. I mean, this has come so far in the last 10 years. So the prevalence is there. I think, I was looking at some market information a couple of weeks back, and that's a few of the data points that I was able to find. So it's very commonplace, very commonplace.
Yeah. I'd like to highlight 80% of IBS. So I think sometimes people say they have IBS like they say they have blue eyes. Like, it's just this thing that I have.
That's right.
It's not something that you need to live with, though. So if you're not looking at the root causes of the IBS, it could evolve to IBD, irritable bowel
Yeah,
disease and cause future problems down the road. So,
absolutely. And you were talking about root causes. So yeah, that's one of the questions that we get a lot. And so one of the primary ones is, if you think about it, is food poisoning, right? There's no bacteria there. You put it there through ingestion of a food. So that's one way. But then you have other ways, as Laurel you were mentioning. Sometimes if you don't have a healthy biome, a healthy small intestine, and so it's a growing ground, so to speak, for bacteria. Let's say, that 23 plus foot tube I was mentioning, it has this action. It's called migrating motor complex. Essentially, it's a term for the action of that 23-foot tube, the small intestine, to push food and drink through and get it into the colon. Well, sometimes that is compromised for one reason or another. When it is, what happens? Food just sits there. It doesn't move through efficiently. That's what grows bacteria and or archaea sometimes. So you have some of those reasons. You could have, and we pick this up sometimes on the test, and we'll call every time to the clinician's office. Remember, I said that it was a 3-hour test, and we're looking at the first 2 hours to see if there's a certain level of bacteria. Well, what if we have the bacteria that met that rise, but it was at the very end of the 2 hours? So it's at 100 minutes, 120 minutes. First thing we do is we call positive if it met that level, but then we also pick up the phone and call the clinician. And we want to talk with the clinician about this, because in some cases, the 3-hour time period, right? Some patients have what they call transit time, the time that you eat something to the time it makes it to the colon. Sometimes that's faster than others when it's slower, as you can imagine. So we always have to challenge those positive results that are kind of right there at the end of that first 2 hours, and just be sure. So we would call and say, did you expect to see a positive SIBO test? Do we have chronic postprandial SIBO symptoms? Meaning, is it every day, any time of day, any type of food that when they consume, they have the bloating or cramping? And if so, then we favor the distal. But where's I going with root cause? So if it's at the distal end, right after right after you finish, the food finishes going through the small intestine, there's like a doorway that goes into the colon. It's called the ileocecal valve. Think of it as a door, and it just flaps open down and stops bacteria from the colon and food from the colon going back up into the small intestine. Well, what if it's compromised? What if the patient had some lower abdomen trauma, or just something happened and it got compromised and the doorway was left open? So now the bacteria is growing up from the colon, and that's where it tends to stay there, the distal end. And that's when you can create an infection that is based from an anatomical issue. So that's just some ideas on root causes.
yeah, that's very helpful. What if somebody has had a surgery for a cancer, or if they have IBD and they've had surgery, and so their small intestine is smaller?
Yes.
How does that impact the test?
Yes. So a lot of times clinicians, if they've had like a resection of the small intestine, removing part of the small intestine, or just mentioned, some of these other surgeries, what they'll do is they'll just include a note with that in with their specimens, and we take that into account because it's a time test, right? So if you have 23 feet of small intestine in plus in every one of us, now if they've taken 6 feet out, what happens? It means things will go faster through. So we have to challenge the interpretation of the data that we see, because if you've shortened that tube, that means the lactulose or the glucose that you consume for the test would get into the colon faster. And if it gets into the colon faster, then you'll get a gas rise, which you should, but that's colonic gas, and that's okay. So if you've had a shortening, so to speak, of your small intestine or some other surgery that we believe might lead the substrate to go through faster, we just have to challenge the results. And this is actually, I'm so glad you asked the question, because I'm a firm believer. I know how accurate our data is. And I think the interpretive approach that we apply, because there are several different approaches to that, to interpreting these data, I think the one that we choose is the most accurate. I think it matches clinical impressions the best. But the test is not the diagnosis. Only the clinician can make the diagnosis. I think the data that we provide the clinicians and the conversations sometimes when we have to have them assist the clinician in making that final determination. But the test result should never be that. It should give you very good, solid information. And you should have the confidence that I have if all the things that I mentioned earlier, from the prep, the kit, to the way that we do things in the lab. And I'm not going to tell you everything we do because I would bore you. But the one thing, just to give you an idea, when you provide your breath sample, as I mentioned, there's this device that you're going to exhale through. That there's going to be a needle that punctures a rubber stopper in a test tube that has never been opened up to room air. It's evacuated for air. So when it's punctured, your breath goes in there, and then that is shipped to the lab. Again, it's punctured and it's vacuumed out, and it goes through a machine with sensors that'll measure the hydrogen or methane levels. What we do, if you were to walk through the laboratory, you'll see 4 blue trays and a red tray. After every red tray of samples, so every 5 patient tests, the technician goes to a hydrogen tank, a methane tank, and a carbon dioxide tank, and takes a known value of the parts per million of those 3 gases and puts it through each machine and logs it. It has to meet a very defined variance, meaning it's calibrated. It's actually measuring accurately. And why do we measure carbon dioxide? Because carbon dioxide is found at constant rates in lung air, trace amounts in non-lung air. So every specimen that you provide is going to tell us if it's your true lung air or if it's room air, right? If it's room air, it's going to give us a false result. So we know that. Then we know the actual hydrogen and methane gas. And again, we don't produce those gases. So if we have it at a certain place on the test, and as Laurel mentioned, depending on if you've had a surgery, we have to adjust that. That's what leads the clinician to very accurate results, which in the end, following treatment, will result in you feeling better, and or your patients, if you're a clinician listening, feeling better than they have probably for many years. Mm-hmm.
Yeah. Thank you for kind of going over some of the upstream potential root causes of SIBO. You mentioned the migrating motor complex and a compromise of the ileocecal valve. And I'd just like to add to that, I've seen high levels of stress, infection, sometimes use of the PPIs, the proton pump inhibitors, a lowering of the stomach acid, which kind of for a lot of people happens with age anyway. And my personal story is there's a couple summers ago, I was at a Dr. Weil's restaurant in Bethesda, Maryland, and I was so excited about this giant bowl of Brussels sprouts that I ate them all. And then my stomach was so bloated, I thought that I was going to cry. Like it was painful. And I'd just been seeing this in a bunch of patients. I'm like, oh no, what's going on with me? What's going on? And did some investigation, and my stomach acid was super low. I also have multiple sclerosis, probably impact my migrating motor complex. So I have had a couple of root cause issues for SIBO. Yeah.
Here's the good news, though. By and large, some may not share this opinion, but by and large, it's an infection. And if you treat it, you can get rid of the infection and feel better.
Right.
It's not,
and
everyone
do
has to live with it.
Right.
Sorry.
And do the things that address the root causes that may have contributed to it as
100%.
well.
Absolutely.
Right.
Yes.
Because as you mentioned, some people are living with this for years and they don't come to seek help until they have an autoimmune disease or they have constant joint pain, which are these downstream effects if it's not treated.
Absolutely.
So you're a businessman. You are a is that okay to call you a businessman?
Sure.
Yes.
Yes.
You're in the healthcare space.
Yes.
So you're not a clinician, but
No.
you work with clinicians. You follow some clinicians. So from what you have seen, you've been in this space for 10 years now. What does a practitioner do? You touched on it a little bit earlier about kind of maybe 3 ways they would handle a positive SIBO result.
Yes. As to what you mentioned, to deal with the actual infection, consider it, generally speaking, like 3 buckets. You're either going to use antibiotics to get rid of the infection, or you're going to use herbal antimicrobials, or you're going to use a diet. It's a liquid diet. It's called an elemental diet, which essentially the elemental diet feeds the patient but starves the bugs. And a lot of people will ask me, okay, we mentioned like the low FODMAPs diet, and there are other diets too. Those diets are very good and are very necessary for improving health, but they're not going to get rid of SIBO. So, the diet aside, that diet aside, the elemental diet is one way that a patient can eradicate the bacteria. The other was the herbal antimicrobials. They'll use a combination of things: berberine, neem, oregano, Alamed, those kind of products to help get rid of SIBO. And then your antibiotics. Typically, what's used is Xifaxan because it stays in the gut. So that's one of the number one products that will be used. Unfortunately, it's very, very expensive, especially here in the United States. And hopefully that changes over time. But it is one that stays in the gut and is pretty much everyone uses. And then if you have methane on a test, they'll add a second antibiotic like neomycin or metronidazole, because there was a study that showed combination products work better, much, much better on those that have methane on their test. With herbals, they would use the whole garlic to be sure to adjust the methane in those instances. So those are generally the three buckets of approach for that. And then you go into the whole good gut health and getting what damage has been done, if there has been, getting you back to the place where you need to be.
Right. Yes. I want to jump back real quickly because we didn't really go into the FODMAPs, but a low FODMAP diet can be helpful to reduce symptoms, but as you said, does not cure the problem.
Right.
And so earlier on, when I mentioned the elimination diet, if clients are struggling early on when they are eating high FODMAP foods, and then we just do a switch. Okay, let's see how you feel with low FODMAP, and then that's another sign that we might need to test for SIBO.
Right.
So then, go ahead.
No, I was going to say your elimination diet. Why, if you're listening to this, why would that be important? Well, remember what I said. The symptoms. If you're thinking SIBO, is it every day, all day, regardless of food? What if you do an elimination diet and you find, hey, it was just this food that is causing these issues? So that's not going to be SIBO by and large, right? Because if you're bacteria hanging out in the small intestine where you don't belong, it doesn't care what type of food you are. Now, certain foods will be more intense than others. Highly fermentable foods will be more intense, but any food is still going to be there. So just to add that.
Right. Okay. So let's say they get a positive result that based on their clinical signs and symptoms, and then they do the breath test and they have a positive hydrogen or methane, and the clinician, sorry, that's my dog, that's Rocco. Then the clinician decides to treat either with the elemental diet or antibiotics or herbal microbials. Then what? Do you retest to know did it work?
Yes. And I love telling this story just like this. When I first started this laboratory, as I mentioned earlier in our conversation, many clinicians weren't even testing. And the reason they weren't testing is the data was so inaccurate, or the interpretation was so bad, or the collection, or the kits, or whatever. So it was useless data. So I understand why they didn't. But when this got much, much better and much, much more accurate and started aligning with clinical impressions, that's when clinicians started testing. Why? You want to test to be sure it's not mold, fungal, Lyme, parasites, as we mentioned a couple of times. But we also want to know if we have methane on the test. As I just mentioned, we're going to treat differently. But to Laurel's question, this is so incredibly important. And I'm not saying this because I want another test. Yes, I own the lab and I'm a business person. However, if you really want to save money in your treatment, and if you're dealing with SIBO, you want to suspect it, test to confirm it. If it's positive, you want to treat, and then following treatment, clinicians vary on this. It can be 14 days after treatment. It can be 10 days after treatment. Some clinicians use other days, but 10 to 14 days typically, you need to retest. Use any lab as long as you trust what they're doing. But if you don't retest, and this is what happens, if you don't retest, if you're given antibiotics or you're given herbals or you go on an elemental diet, 9 times out of 10, you're going to feel better. Life is going to improve. But if you don't retest to confirm, what happens is the bacteria will repopulate. It's like pulling a weed, but not the root, right? What happens is it just grows back. And so why do I stress this? Because if you suspect this, not only are you in pain and not feeling comfortable, maybe you have also constipation or diarrhea, so it's limiting what you can do in your life. But then you spend the money to go see a good clinician. Then you spend the money on the test. Then you spend the money on the treatment. And then you might say, oh, I don't want to retest because that's just another cost. That's fine. But what happens if it's the weed and the root situation and it repopulates? Now you're back to going back to the clinician. The clinician has to order the test again. Now you have to get the antibiotics I just told you that could be very expensive in some cases. You want to tighten it down. So suspect it, test to confirm it, 10 to 14 days later, retest to be sure that it's gone. And if it's gone, the likelihood of reinfection is much, much more limited unless there's an underlying situation, as we mentioned, like a compromised valve, or if it's food poisoning, is your lifestyle, you're introducing some of these foods into yourself. So anyway, just 10 to 14 days after retest.
Great. Yeah, thank you for sharing that. And also thank you for sharing kind of the history and why 10 years ago, 5 years ago, even people were like, maybe we just treat because the testing is not accurate. So how has the science has evolved?
Yes.
More and more studies are happening on SIBO. And how has the testing evolved over time?
So the testing has evolved, quite frankly, because what you had in the past, as I mentioned, is you had varying types of collection devices and varying types of approaches to the preparation. And then remember that story about the Brigham, which is a fantastic hospital, but the way that they were administering the collection of the breath and the directions led to the results not matching accurately. So I think it's about the development of the breath collection kits, the closed capture kits. You have a lot of laboratories, not a lot, but there are laboratories that are out there that might use a screw top test tube and a straw, or they might have a situation where there's a collection bag that has a device that you open up and then you close it and you blow through it. And I'm sure there's good data on all of those, but from my experience, the reason I used the kit that I use, and I didn't develop it. I buy the kit and I use it because of what we discussed earlier, it being a closed capture kit. But then, to your point, there's been a lot of research in this space. And so it's growing in a lot of circles. Some of the research I appreciate and some of it I'm still questionable on. So I don't really talk to it. I know all about the research and I know all about where some of the guidelines have gone. There are different interpretive approaches to these data. So let's say everyone was getting accurate data. Once you have the data, then you have to make a decision. We mentioned earlier about like the 120 minutes. I still look at the full 120 minutes. Some labs will cut it off right at 90 minutes. And the theory is after 90 minutes, you're in the colon. Mostly that would be true, but not all the time. How about if you're a constipated patient? How about if you have slow migrating motor complex, slow transit? Then you're not going to be. So you would get a false negative with that approach. That's why I mentioned that we always look at the first full 2 hours. If it's only positive at the very end, we call it positive because that was the Hamilton/Rome consensus approach. However, we go a step further. We pick up the phone. We call the clinician. We announce, hey, this is at the distal end. This could be the substrate going into the colon. So this could be giving you a false positive. So let's talk about this patient. And that's how we mitigate some of that. So the question was, what has evolved? And I think it's the approaches to treatment. I think it's the testing from a closed capture device. I think it's some of the things that we do in the lab that Maybe others don't. I talk to you about calibrating these machines. The manufacturer doesn't suggest calibrating them every 5 patient tests. It's like once a day or every 100 tests. Well, that wasn't good enough for me. I wanted to have the confidence that if I returned a positive or a negative to you, Laurel, that it matched 100% to your opinion. So if you suspected SIBO, you're getting a positive result back. That gives you that level of confidence. So there are times when a clinician will call because they'll say, hey, look, you gave me a negative, but this is classic SIBO. And I'm always going to say that the clinical always overrides the test. So if you feel you're dealing with SIBO, you should treat that patient. However, my level of confidence is so high on this data. Why? Because when I'm looking at a result, I know you all don't have one right in front of you, but picture a table of data. You're going to have 10 data points because the patient collected 10 breaths. You're also going to have CO2 numbers. We talked about this earlier. The first thing I do is my eye goes to the CO2. If I've qualified each specimen for true lung air, right, then that's a valid sample. The baseline, the first collection that the patient does, should be very low on hydrogen and methane. Why? Because if there's no food and they prepped, remember, 12 hours limited diet, 12-hour fast. If there's no food in that GI tract, there can be no gas. Just our bodies don't produce it. So I look at the CO2, all good. I look at the first row, low numbers, they prepped right. Now they drank if it's lactulose, I'll know if they drank it, right? Because they're going to drink the lactulose and it's going to go through all 23 feet. And again, if you're bacteria or archaea, you're not going to sit back to, I'll wait for some other food later on this afternoon. It's going to ferment. If it doesn't, that lactulose will enter the colon where there is and should be bacteria, as we discussed. So now you have this bolus of gas at the end of the test in the 3rd hour. So we know we have good lung air. We know the patient prepped correctly. We know they drank the lactulose because we can see it in the colon. So there's no way there's an overgrowth from my perspective, right? Now, we do have a third gas that isn't, in my opinion, isn't currently, we have not found a way to accurately measure that, in my opinion. It's a hydrogen sulfide gas. It only occurs, from what I'm seeing and from all the conversations that I have, and I've done over 100,000 tests, we're seeing in 1% to 2% of patients, but it's the new thing, so everyone's talking about it. Our research and our experience has been that you can't measure that gas in parts per million. It has to be measured in parts per billion because it's a very sticky, so to speak, gas. It requires a large volume to get it right. That's the other problem. To get a large volume of lung air, you would have to almost inhale a little bit more deeply than just exhaling normally. And we want you to exhale normally because if you inhale deeply, what's going to happen is you're going to do that. What are you doing? You're bringing room air in. You're going to mix room air with lung air. We're going to catch that. That's why we give the actual CO2 numbers to say, hey, this isn't a lung air sample. This is room air. That's why you're getting, negative methane and negative hydrogen numbers because they're just not matching up because it's being mixed with room air. The other factor on this, and I don't want to talk too much about sulfur gas because I'm really not seeing it that much based on our doing all of our testing and the kind of questions and working with the clinicians. But hydrogen sulfide gas is produced in our body. Hydrogen and methane gas are not. Hydrogen sulfide gas works through the nervous system and it's used in cell signaling. So, okay, let's say we could measure it accurately. What's normal? What's abnormal? The jury is still out on that. People that are talking a lot about it, it seems to change from 1.2 is abnormal to 5 to 3 to 2. So I think we're a little ways away from that one right now. But the good news is that the researchers are working on it, and I hope that it can get very accurate at some point where you can test for that as well and help that, in my opinion, 2% or so.
Okay, good. And you mentioned a couple times accuracy of the test. There's some ways to show on the data, yes, they did this correctly. They fasted. They didn't take in a big, deep breath. So are there ways, do you have a video or how do you help people do it correctly? Because it's a long test.
It is. So here's the good news. If you're listening to this, it's a 3-hour collection, but you don't have to stop your life for 3 hours. The prep is not like a colonoscopy prep. It's a boring day of food. So think about it this way. You're going to get this box. It's about the size of a brick. And it's going to have a collection device, and it's going to have, for SIBO test, 10 test tubes. And what you're going to be asked to do is prep for that 24 hours. So essentially, if I'm going to collect on Saturday morning, Friday, I have to eat boring food: chicken, fish, turkey, white rice, white bread. It's boring, but this is going to help you to figure out what's going on with you. So it's easy. As far as the kit, and like Laura asked, what do you do? Well, on our website, there's a very short video. It's very simple, but there's also instructions inside the kit. We're always available to answer questions at the lab. Nights, weekends, whenever, you just let us know in advance and we'll coordinate with you for that. But more importantly is our model. Again, it was my intent to get this right for the patients. I believe I'm the only laboratory that does this, but you don't hold me to that. But when we get an order, if Laurel was to place an order for a patient today, one of two things is going to happen. She might stock some of our kits in her office and actually hand you a kit. And then she sends us a requisition so we know that you have that kit. Or she's just going to order directly from us, and that kit goes directly to your home. And so you get it that way. Either way, when we know you have the kit, we will outbound call you. Our customer service team will outbound try to get you on the phone and ask you, hey, do you have any questions about collection, preparation, return shipping? You know, we send the kit, or you're handed the kit. Inside the kit is prepaid 2-day UPS or FedEx service back to the lab. The day that we get it, 1 business day later, the results are in your clinician's hands, unless there's something that you didn't do. You didn't sign your paperwork, or, you know, there's something that we needed. We very rarely will hold a report. We always process specimens the day that we get them, or the very next business day.
Okay. So best to ship it on a Monday, Tuesday, Wednesday, and not a holiday.
No, that's fine. No, you can ship it anytime. The specimens are valid. They're remember what I said, that they're vacuum sealed. They're not going to leak. You can ship them anytime. We've actually produced a test result a year after the patient collected, because they collected their breath, put it up on a shelf, and forgot about it. Then they called and said, well, what should we do? Retest? I said, send it. Let's see, because if the CO2 is correct, then we know that there was no breach. And how would you have a breach if it's vacuum sealed and has the rubber stopper? Well, let's say they put it up right next to a heater or something, and it dried out that rubber stopper. It would leak. We would get room air in there. We would know. So if the CO2 is good, we know we have a valid sample. Now, in that case, it doesn't matter because it's a year later. That's not the same small intestine at that point. So more than likely retest, but you don't have to worry about nights, weekends. Now, I will say this, and I think we're the only ones that do this also. As I mentioned, we have a 24-hour, 1 business day turnaround time. Okay. I don't think there are any other labs that are doing that. And I do that because I know what it's like to be on the other end waiting to hear do I have this, do I not, etc. But if your clinician decides you're going to do elemental diet, remember what we said about elemental diet. It is feeding you, but starving the bugs. So you don't want to do this for 7 or 14 days, however long that they prescribe the diet for you, and then do your test and go back to regular food before you know what the answer is. So what I always say is, let's say you're going to do 14 days of elemental diet, or 7, let's call it 7 days. You want that to end. You want that to end on a Sunday or Monday, to your point earlier, Laurel. Why? We want to get that. Those samples back to the lab within 2 business days, and we want to then return that answer to the clinician within hours, not within a business day, because once you're not going to go to the prep diet. If you're doing elemental diet, that is the prep diet. You're just going to go into a fast overnight. So if you finished on Sunday, you take your last drink, then you go overnight with the fast, you collect your breath, you ship them out to us, then you stay on the elemental diet until we give you the answer. So let's say in this scenario, we get your results on Tuesday or Wednesday, and we know, because you alert us, that you've been on elemental diet. Then we go through all the shipment that we get. We look for your name. If we have your name, you go right on the machine within an hour. we're reporting the results to your clinician so that you could either continue to stay on the elemental diet or you can go off now and move on because you've eradicated it.
Okay, that's awesome that you have that get to the head of the line process for people on elemental diet.
Yeah, and we can do it with any patient. If you have a real specific need, I mean, we can always do it, but it's typically the elemental diet because there's not going to be a real change with the other patient population if you're on antibiotics or herbals.
Right.
Yeah.
Super helpful. Okay, so you're in the testing world, and hopefully this has kind of just anybody who's listening at least brought maybe some awareness if they had never heard this before. If someone suspects that they might have SIBO, something that you said that we talked about today made them scratch their head and think, oh, this maybe could be me. What should they do?
In my opinion, if you are sitting there and you're feeling like some of the things we discussed today, that every day I just don't feel right, whether it be diarrhea, constipation, bloating, cramping, nausea, joint pain, restless leg syndrome, rosacea, some of the other things that Laurel and I discussed, then I encourage you to seek out a clinician that understands SIBO or that is open to understanding SIBO and or intolerances, and consult with them. Can you purchase a test directly? Yes, you can. But we're going to encourage you to still reach out to someone because we can't speak with you about what the actual diagnosis is. We'll be able to show you on the result where the gas is and if it met or exceeded those thresholds. But you're still going to need a clinician to help you with treatment. And really, the clinician is the only one that can really diagnose this because, yes, if the data is there, it's pretty binary. It's there. However, as I mentioned, it'll never be a diagnosis. So you'll need assistance with it. The good news is it's an easy process from a discovery, as we mentioned. Suspecting it, the diet's easy, the collection's easy, getting it done. The treatment can be easy. But as Laurel also said, it's not just about eradicating the bacteria. It's about returning, your biome back to where it needs to be to function properly, to lessen the impact of what could be the downstream effects, which, when you have infections and they stay for longer times, you have destruction of certain, organs and things that really you require to live a good life.
Yeah. Thank you. Any special resources that you would like to share that people can learn more?
Absolutely, yeah. So there are a couple of resources right now that are out there. If you're out, on the web, one that I use kind of as a dictionary, it's the go-to. It talks about just about everything SIBO is SIBOinfo.com. And that is, it's Dr. Alison Seebecker's site. It's a wealth of information. So that's one. You also have the SIBO Doctor, which is another one. That's Dr. Norala Jacoby. She's based out of Australia. Wealth of information on her site as well. She does podcasts. You also have Dr. Joshua Goldenberg, who does a podcast as well and is oftentimes dealing with a lot of these issues. I'm probably forgetting half of them, but there are some GI gastroenterology resources. I tend to kind of align more so with a lot of the functional, integrative, naturopathic, nutritional medicine clinicians. Not that there was any issues with the gastroenterologist, not near that, but many, many clients that are very good, that do a great job. It's just, I don't know why we tend to go more toward functional and integrative. They seem to be more focused on SIBO than some of the other, good subspecialties. Yeah.
Right. And we talked at the beginning about there is an option of direct to consumer. Mm-hmm. So if somebody, they wouldn't get a diagnosis, but they could get the data, say that their family or even their doctor was dismissive of their their symptoms, or they told them it was all in their head, because
Yep.
I've heard that before, they could direct to consumer go and request a test to get the data.
Yes. All you would do is go to aerodiagnostics.com, and that's it has an S on the end, Aerodiagnostics, and that's AERO diagnostics, diagnostics.com. Right at the top, it says order a test, and a test will go to you. There are certain limitations with ordering a test directly. One, the kits have to go to a street address, not a PO box, because we use FedEx and UPS. The other is lactulose is a prescription in the United States, so you won't be able to order a lactulose test. You can order a glucose SIBO test or any of the intolerance tests. If you want lactulose, you can order a kit without any substrate, and then you can go to your clinician and ask them to write a prescription for the lactulose. And if they need any assistance, we can work with your clinician. If you want to just call customer service and see if where you live, do we have anyone that we might be able to refer you to, we can do that. Some of the other considerations by ordering direct is obviously you'll get a receipt that you could submit to your insurance, but we won't be able to file a claim with your insurance because it has to be ordered by a provider that's licensed to order tests in their state. And then I think there was something else I was forgetting, but I think that's no, we talked about the insurance. Sorry, I think I got everything on that.
Okay, so insurance does cover this test if it's ordered?
In some, it depends. And here's the thing: we file insurance. If we get an order from a clinician, we can file a claim. If it's Medicare, if you're straight Medicare, not Medicare Advantage, there is a specific coverage determination against, meaning you can't file a claim for SIBO with lactulose. There is not one with SIBO with glucose. So with SIBO with lactulose, what happens is, if you're Medicare, straight Medicare, we have to file the claim, but it's going to get denied. And then you drop to what we call just the cash pay price, which is $209.74. If for any patient, if you can't afford $209.74, you simply call our office, fill out a form, and we work with you on, how to get you access to the test. If you're Medicaid, we don't cover, we don't participate in Medicaid, so that won't be an option. So it's cash pay. And again, we can do financial assistance on that. If it's commercial insurance or Medicare Advantage, again, both of those we can file. If it's Medicare Advantage, again, the whole lactulose thing, keep that in mind. But if it's commercial or Medicare Advantage, you're going to pay $99.74 up front, your initial payment, and expect that you may have to pay an additional amount of $110. The $110 plus the $99 gets you the $209.74. We will file the claim, though, after your initial payment. We will file the claim, see if they pay. If they pay, then you may not have to pay that $110 extra. If, again, you need assistance, you can ask, for that. The reason you can't say who pays, who doesn't pay, the insurers in the old days, back in the 90s, you called your insurer and say, "Hey, I want to take this test. Would you cover that?" They would say yes, and they would actually cover it. Now what you're going to do is you're going to call your insurance company and say, "Okay, I want to do this breath test, and the CPT code is 91064." I don't know. I can't remember that code number right now, but it'll come to me. But anyway, we give you the CPT code, and you'll call, and they'll say, "Oh yeah, we cover that." But if you don't ask the second question, is how about did I meet my deductible? Do I have a copay? If you have to ask all of these questions, they may not give that information to you, because I get a lot of frustration with patients is, I called and they said we cover that code. Yes, but you have a $2,000, $5,000, $7,000 deductible and you haven't met it. So guess what? It's going to come back down to you. The good news is that if you pay timely, you can pay the $209.74, or if you need help, we can work with you on that. So I can't tell you if your insurance company will pay for it. Depends on where you're at with your deductibles, copays. It depends on your plan. We can give you some advice on it, but really it's going to be, I would go into it expecting to pay somewhere between 0 and $209.74. And that's kind of what we found to be just the most accurate way of working with the patients to help them through this process.
Right.
Mm-hmm.
Right. Thank you for that. And I have to go backwards and ask a follow-up question on the lactulose glucose. So I'm not a doctor. I can't write a prescription. Can I request a SIBO test with glucose substrate?
Yes. Glucose is just
And
table sugar. Yep.
and accuracy between the two, how do they play?
Yeah. So I would not offer both if I didn't believe that both are highly accurate. However, if you go on the internet, you're going to get opinions, strong opinions both ways. And here's the situation. If you're a firm glucose believer, you're going to think that lactulose is going to give you false positives. Remember what I said about the lactulose going into the colon faster and the issues with the tests that with the studies that were done on lactulose is that it had a lower sensitivity and specificity because it was giving more false positives. However, if you approach interpretation the way that we do, you reduce those false positives because you're challenging those distal, as we mentioned. So those with glucose, typically you're seeing that a lot with clinicians that can't write a prescription for lactulose, or you're seeing it in GI. A lot of GI docs will use, and again, that's a very broad statement. Not all GIs use glucose, but I would say by and large, that's what we find. Functional integrative naturopathic medicine tends to use a lot more lactulose. There are some very big research GI sites that use lactulose for sure, and I told you about some of the good reasons to use lactulose. But with that, the folks that use lactulose say, well, glucose is going to give you a false negative because glucose is absorbed in the body, and they're going to say it's absorbed in the first 2 feet, before you get to the end of the small intestine. So you'll miss that distal infection. It's their clinical impression and practice that they feel that way, but the data just doesn't support it. Matter of fact, I had one very, very well-known SIBO thought leader, and I was having this conversation with her because when she speaks, she was talking a lot about how important it is to use lactulose. But then there's this whole cohort of clinicians, nutritional medicine, naturopathic medicine, that can't have access to that. So it was kind of, shutting them down from being able to test accurately. And so I said to her, I'll tell you what I'll do. I'll take 5 patients, blind it, give them both a lactulose and a glucose on different days, and I'll guarantee you that they come out the same answer, positive or negative. And they did. And she went further and said, well, I have this group that I work with in Portland, and there are 4 other clinicians. Will you do it for them? And I did. And guess what? They both came out positive or negative, both right. There may have been 1 or 2 where we had to have that conversation about the distal, with the lactulose. Well, is this really positive or is this negative? But by and large, it came through. And so in our follow-up conversation, she's like, you proved it to me. You proved to me that it's accurate for telling us whether there's SIBO or whether there's not. And then the one thing that she said was, well, Gary, the reason why I like lactulose is because my practice is when I test, depending on the parts per million level, it's how I'll approach treatment. And I said, well, I understand that. That's her way of using the hydrogen and methane test. And I'm not saying that she's wrong. It's just that there's no data to support that. This test, and there are offices that do this test was never intended to be a severity test, meaning I have a more severe case of SIBO than this other patient, right? Because if I had 200 parts per million, it's more severe than 25 parts per million. The test was never intended for that. There were no studies that I've ever found with the endpoints of severity and being able to actually tackle that question that does that. You'll see a lot of that information in studies as an opinion of the author, meaning, oh, I have a severe case here because it's 200, but that wasn't the endpoint of the study to find out if it's severity or not. And even if I lose that argument, what do you do differently? So if you did a test today and it was 200 parts per million with one patient and 25 parts per million rise with another patient, and you're going to treat, what do you do different? Well, the one clinician that I was talking to, she said, well, I will prep the patient for a longer treatment approach. Okay. But the dosages of the treatment aren't going to differ. If you're using antibiotics, you're still going to use the same dose, the same duration, right? Now, to her point, you might go further, and that's valid from her perspective. But I would take these tests as binary, presence or absence. Do I have this overgrowth? Do I don't? Do I have this intolerance? Do I don't? Or, and then treatment and approaches to treatment. Would I disagree that if I saw 200 parts per million, means that there's got to be a lot of bacteria there. So maybe the first course of treatment, maybe that won't be enough to tackle it. But let's do some studies and see if we can really prove that.
Right.
Yeah.
And as you mentioned, the studies are growing.
Yeah.
We're doing more and more studies. And I love the story that you shared about blindly testing patients with both substrates and getting the same results, because that makes me more confident in being able to use the glucose substrate with confidence.
Yeah. And, on this note, Laurel, I love that there's a lot of research. I would like to see a lot more, and I would like to see a lot more from multiple centers, not only in one place in the United States. I want to see it all across the United States. I want to see it all across, Europe and other areas. Because if we could standardize, and I know there's been several attempts to standardize how you interpret, I don't align with those, and this is not the right forum for that. I think I have some very good reasons, but my question now is, I like to see the research, but now I have to question the means by which we got to those ends. What diagnostic was used? How was it employed to get to that, right? What are the outcomes? What are the outcomes from treatment? So those are some of the things. I'm glad that there's some, but they seem to be localized. And I would rather see different opinions using different diagnostics, not different in, blood, or, it's going to be breath testing to diagnose these, but can we be sure we know how the patient prepped, what collection device they used, how are you calibrating your machines to be sure they're reading accurately? Because then we can say, the research is telling us something because we can believe in the data.
Right. So that you're always comparing apples to apples when you're comparing different research studies. Yes,
exactly.
Yeah. Well, we're still early days, but thank you so much for, bringing awareness to something that people may not have been aware of before this conversation. Thank you for your efforts and passion to make like a test that is accurate and accessible. I appreciate that greatly. Is there anything else that you want to share before we wrap up?
Well, thank you. The only thing I'd like to share is I always make myself available. If you have a question, whether you're a patient or a clinician, I'm always available. You can reach out to Aerodiagnostics and we'll coordinate a call. The one thing I would caution is I am, as Laurel mentioned, I am not a clinician. I can't speak to you about your health, and I can talk about the test and talk about what the test will do. But a lot of times patients want to call and they want to give me their medical history, and it's not only inappropriate, it's not the right thing. You need to be with someone like Laurel or her colleagues, because they're going to understand the full breadth of what you're saying, where I'm very narrowly in a space here with regard to a diagnostic, and it's breath testing. So that's not who you want to entrust to your healthcare, other than outside of me giving really solid results.
Yes, but thank you for what you're doing to create your test locally. Last time I used a test, we shipped it to Europe, and that's time consuming.
Yeah.
And we were not able to get the data the next day. It was multiple weeks. So I appreciate that you're also very quick on your results.
Thank you.
So yes, thank you so much, Gary, for your time and for sharing your knowledge and expertise with us today.
It's a pleasure. Thanks for giving me the time.